cell of the immune system is the one which is shown in the histology of the liver. You know that ito cells are the ones associated with the vitamin A storage, and Kupffer cells are the ones which are part of immune system. You should recognize what is the type of inheritance pattern. So fundamentally, a female is affected means it is not X-linked, unlikely to be X-linked recessive. And whether a male or female is affected, a male or female child is affected, also says it is autosomal but not X-linked. Then the ratio at which the affliction has happened, typically this is a pedigree of autosomal dominant pattern of inheritance. So congenital erythropoietic porphyria is the one which is basically autosomal dominant in nature, is what you need to basically remember. What is its appearance on electron microscopy called as basket weave pattern, which is a typical thing whenever the splitting of basement membrane occur in Alport syndrome. So classically an example of Alport syndrome typically. Now you have a glomerulonephritis which is being shown to you, and if you look, the presence of neutrophils, narrow cap, and the type of immunofluorescence pattern, it is a classical thing of lumpy bumpy immunofluorescence of post-infectious glomerulonephritis. So in this you will find crescents, granular deposits of IgG, subepithelial deposits, and remember doctor, one histological slide in NEET PG invariably comes from the topic of glomerulonephritis, which you have to be very, very sure about. Now, typically in post-typical glomerulonephritis, the laboratory values have been shown to you. Which value will come down, that is decrease, remain decreased for a period of 6 weeks, and then it will increase. Classical of complement values, because it is an immune complex deposition disorder, there is a hypercomplementemia. But a hypercomplementemia doesn't persist beyond 6 weeks. By the end of the 6 weeks, once more the complement levels are improved. If they don't improve, it is against the diagnosis of PSGN, post-streptococcal glomerulonephritis, a very important favorite AIMS question which you have to be very sure about. Now, what is the type of necrosis pattern this is? This is coagulative necrosis, where the cellular architecture is remaining intact, is what need to be remembered. It is seen in spleen, heart, kidney, but not in the case of the brain, is what I want to underscore to all of you. Now, what is this histopathology? Typical of old-eyed cells of Hodgkin's lymphoma. So what are the CD markers? CD15 and CD30 are the ones which are typically involved, is what I want to make you remember. What is a type of Reed-Steinberg cell? Pella, how many types of Reed-Steinberg cells that you know? There is a lacunar type, right? So this is an example of a lacunar type where you are having a clear halo around the Reed-Steinberg cell. So it is a very classical thing that you see in case of the nodular sclerosis. So you have a classical Reed-Steinberg, mononuclear variant, lacunar variant, and lymphocytic variant of Reed-Steinberg is what I want to underscore to all of you. Ideally, I should not put arrows, but I thought I will be too cruel to create such a karyotype for the wonderful MBBS students and kill their peace. I have much better ways of killing your peace, right? But if you look at recent image-based questions given in AIMS and other exams, karyotype-based questions are very common. Surgical instruments, Datta, obstetrics, back may, you will have different surgical instruments. 8-14 translocation is a classical thing that you see in case of Burkitt's lymphoma is what you need to basically remember. Supravital stained peripheral smear, which is being shown in the figure. So what is it basically showing you? Typically it is showing the hinge bodies which have got, this is called golf ball. You know the player Tiger, golf player, right? So golf ball appearance is typically seen in HBH disease. The hinge bodies is what I want to underscore. Now a peripheral smear is showing fragmented RBCs. What are they called? Cystocytes. So cystocytes are a typical feature which is seen in the case of the microangiopathic hemolytic anemia, which is thrombotic thrombocytopenic purpura. Now what is this peripheral smear basically showing you? The peripheral smear is showing you the presence of spherocytic cells and some of the reticulocyte also is increased, which is typical of hemolytic anemia. In this case, it is an autoimmune hemolytic anemia. What is this structure inside the RBC? It's called Cabot's ring, right? So Cabot's ring is a classical feature which you see in case of the megaloblastic anemia is what need to be remembered. Now in which AML do you see the gingival hyperplasia as a feature? Typically in M4 and M5, gingival hypertrophy is an important feature. Now a peripheral smear has been shown to you. Where do you see this kind of a peripheral smear? This is called the pseudo-Pelger-Hute anomaly, which is a very classical feature which you see in case of myelodysplastic syndrome is what need to be remembered. Now the histopathology has been shown. It is showing fibrinoid necrosis and hyperplastic arteriolitis with a onion skinning, which is classical of malignant hypertension. It is the hallmark of the malignant hypertension. Now, there is one characteristic radiological finding in a newborn presenting with dyspnea. Can you see here? This is typically interlobar septum is having a fluid collection, right? So that is a very classical prominent horizontal fissure. Can you appreciate this is a prominent horizontal fissure, which is a classical feature which you see in case of not pneumonia, sorry, answer is given wrong here. It is not pneumonia, transient tachypnea of newborn, one correction in the key. Transient tachypnea of the newborn, prominent horizontal fissure is a very, very classical feature. So, have you seen the movie Dhoni? Yesterday I have seen a late night movie at 10:30, MS Dhoni, the story untold. You have not seen? अरे नीट पीजी जब जा रहे हैं आप एग्जाम के लिए, MS धोनी का मूवी आज शाम ही जाके देखिए. He'll be sitting in railway station. I am becoming a TT, expected to become a cricketer. As MBBS student also, while preparing for entrance, lot of times we'll be looking into sky and watching. मेरा जिंदगी किस दिशा में जा रही है? So I had tears watching that movie. You know, I am uncontrollably crying. So my wife was saying that, what happened to you? You are crying like a small baby. I said, "Arey, हमारा जिंदगी है." Even as medical students, oh my God! Every day when we wake up, when we see the students who are preparing for entrance exam, I am like that old teacher in that movie whose job is to stimulate the students to win. Definitely देखना है आप. I am telling you, that will make you energetic. MS Dhoni movie will make you energetic for another 15 days to sit and study and prove the world that you can crack the NEET PG. Really good movie. So, in which of the following disorders do you see this kind of barium study? we see a lead colon pipe-like appearance, lead pipe-like appearance of the colon, which is a typical feature. When in ulcerative colitis there is a loss of haustral folds, then typically you get the appearance. A neonate is investigated for the jaundice and a biopsy has been shown to you. So this is typically a pattern which is called as giant cell hepatitis. Giant cell hepatitis, where there is a loss of the architectural, there will be a architectural disarray, and which is a very classical feature which is seen in case of alpha-1 antitrypsin deficiency, is a predisposing factor. A 7-year-old boy has got bone pain and was detected to have the bone metastasis, and histology is being shown to you, which is classical, very classical histology. So which tumor that is? It is a clear cell sarcoma which has got this kind of histological appearance, is what you need to appreciate, which can present like a retroperitoneal mass lesion. Now what is this lesion which is caused by a infectious organism? Typically what you are seeing is a staphylococcal infection, bullous impetigo is what you need to remember. Now what is this lesion? Where the hair follicles are matted with a black material, which is it is basically called as black pydra, and there will be a black nodule which is arranged irregularly on the hair shaft, which is caused by Pydraria hortae, which is a superficial dermatosis, mycosis is what you need to basically appreciate. So what is the mutation in which the collagen is abnormal typically in this condition? So in a newborn child, this is called Epidermolysis Bullosa, right? So which is fundamentally because of a problem in the collagen 7. So there are two challenges here. First, you should recognize, looking at it, that it is Epidermolysis Bullosa, where there is a Nikolsky sign positivity, right? If you apply pressure, there is a slipping of the epidermis overlying the dermis, and it is due to collagen 7. A person has got muscle weakness, and typically the lesions on the knuckles are Gottron's papules, heliotrope rash, Gottron's papules, classical features. So it is a typical thing that is seen in the case of the dermatomyositis. Then once more in dermatology, doctor, pemphigus vulgaris, bullous pemphigoid, IgA, dermatitis herpetiformis. One out of these three, without that there is no question paper. 100% you should be sure. Desmoglein, what type it is, which is epidermal, which is subepidermal, which is in elderly people, young people, which is tense, which is flaccid, which involves oral, which doesn't involve. All these things you have to be 100% sure. So here there is a deposition of the immunoglobulin along the dermoepidermal junction. So dermoepidermal junction involvement is a classical feature of linear IgA dermatosis, is what you have to basically remember. Now a lesion is being shown in the figure on the skin, and typically this person, if you apply with pressure, that's called diastropy, a slide with pressure, it looks like a jelly of apple jelly. So such an appearance is a feature of lupus vulgaris, is what I want to underscore to all of you. This is a little difficult question to answer, but still this was one of the previous AIMS question in radiology. This is called bracket calcification. Just like a bracket, you get calcification. So such a bracket calcification is a very important feature which you see in case of the lipoma of the corpus callosum. Now a dynamic CT picture is being shown to you, where this is called as dot like appearance. Dot like appearance, it occurs whenever there is a Caroli's disease where completely the bile duct is aplastic, agenesis of the bile duct is there. So it's called the central dot sign. So typically when you see in the lesion, it looks like a central dot. So central dot is a classical feature in case of central dot sign is a classical feature in case of Caroli's disease is what I want to underscore. A 20-year-old with a fifth cranial palsy on T2 weighted MRI is typically shown a hyperintense lesion which is involving the area where cavernous sinus is located, and that is the reason it is a cavernous, it is a schwannoma. So trigeminal schwannoma on MRI, which is typically presenting like a hyperintense mass lesion in proximity of the cavernous sinus, and along the bay of the cavernous sinus you have the fifth nerve, sixth nerve, etc. So that is the reason it can involve the sixth or fifth cranial palsy whenever the schwannoma is located. Now you have done the ultrasound of the gallbladder, and typically you are finding the lesions attached to the wall which is throwing shadows, right? So this is a classical feature of adenomyomatosis where there is a diffuse wall thickening with hyperechoic nodules, and this is called comet tail appearance. Very classical feature. Comet tail appearance is a name given for it, which you should basically remember. Now, what is this radiological appearance? In which congenital heart disease do you see this kind of a radiological appearance? The heart looks like an egg which is hanging to a very narrow pedicle which is like a string. So, egg-on string appearance is a very, very classical feature which is seen in case of uncorrected transposition of the great arteries. Whenever transposition occurs, what will happen? Aorta arises from right ventricle instead of left ventricle. If left ventricle, if the aorta arises with a lot of pressure of 120 millimeters of mercury, blood is pushed into aorta. But right ventricle is like a sweet mom, left ventricle is like a tough dad. So a sweet mom always pampers the kid. So the right ventricle will slowly leak a little like a spoon-fed baby. It will feed the blood into the aorta. So aorta loses its prominence. After all, the hilum, the prominence is because of the aortic notch. When the arch is created, when it is prominent, then only the hilum will be prominent. So in this case, the hilum loses its prominence and it becomes almost like a string, right? And who is taking the brunt? It is the right ventricle which is taking the brunt, right? So ultimately the right ventricle will undergo enlargement, and that typically creates that globular appearance of the heart with the hanging along the string is what need to be remembered. So this is how you should need to transfix. The heart will have the shape of a egg is what I want to understand. Narrow pedicle, right border of the right atrium, left border is left ventricle, and increased vascularity, hypoplastic thymus will give that appearance. Now what is the likely diagnosis in a newborn who has got hemivertebrae and whose plain X-ray is being shown, where there is a lot of gas shadow visible in the thorax? That occurs whenever there is a congenital diaphragmatic hernia with the herniation of the intestinal loops into the thorax, leading to the appearance of the gas shadows in the thorax is what I want to underscore to all of you, and that is congenital diaphragmatic hernia. Now what you are seeing in the lateral radiograph and the PA view is presence of a mass in the anteromediastinum. So what are the four lesions which are classically called give me the board, which are classically called the four T's of the anteromediastinum? T for thymoma, T for teratoma, T for terrible lymphoma, T for retrosternal thyroid. The 4 T's which are called the anterior mediastinal mass lesions is what I want to underscore to all of you. Now, what is the appearance of this lesion which is being shown to you? Very classical about. This is the gross appearance. First of all, it is a mass which is located within the pancreas. So, pancreatic mass lesion with central fibrosis which is being shown. And when you took the gross appearance, it is classical of serous cystadenoma. It has got a central sunburst type of calcification. Sunburst calcification, it looks like a sunburst. It has got a spongy appearance, which are the classical features which are typical of serous cystadenoma is what I want to underscore. Now what is this lung fields? How are they looking? Are they looking oligamic or plethoric? They are looking plethoric, full of blood, lung fields. So lung fields full of blood will occur when the pulmonary circulation increases. Pulmonary circulation increases in ASD, VSD. Why? In ASD and VSD, left-sided blood moves from left to right shunt will occur, right? ASD, VSD. All that increased blood coming to the right side passes through the pulmonary artery, and from pulmonary artery it goes into lungs. So similarly, total anomalous pulmonary venous connection. In all these things, the lung fields are typically plethoric is what need to be remembered. I'll make it more clear for you. So typically you have a heart. If it is a ASD or a VSD, from the left VSD left ventricle into right ventricle, ASD left atrium into right atrium. Ultimately from the right pulmonary artery arises. So there is an increased blood flow going into pulmonary area, right? So lungs become plethoric. Then if you take total anomalous pulmonary venous circulation, what is the meaning of it? Normally pulmonary veins are supposed to drain into left atrium. SVC, IVC drain into right atrium. Anomalous pulmonary venous circulation means instead of draining into left atrium, they directly drain into right atrium, and that also increases the blood flow across the pulmonary artery and creates pulmonary plethora. But what is Epstein's anomaly? Typically in Epstein's anomaly, the tricuspid is atretic. Whenever it is atretic, there is no blood flow coming into right ventricle. So there is a decreased blood flow into pulmonary artery, and typically pulmonary lung field become oligamic. That is what you need to basically remember. Okay. So tell me, doctor, what are the 4 T's you will remember when it comes to cyanotic heart disease? Once more, there are 4 T's for cyanotic heart disease. T for tetralogy of Fallot. T for total anomalous pulmonary venous circulation. T for truncus arteriosus. T for tricuspid atresia. In all this, there is a right to left shunt, right? And that makes it to become a cyanotic heart disease. But how do you differentiate them? In tetralogy of Fallot, which is cyanotic heart disease, what are the combination that you have? You have a VSD, you have a pulmonic stenosis, you have a overriding aorta opening mouth into both the things, right? And you have a right ventricular hypertrophy. But this is a cyanotic heart disease. Why it is cyanotic heart disease? When the blood comes into right ventricle, unable to negotiate through the stenotic pulmonic valve, it will negotiate into overriding aorta, which open mouth into both left and right ventricle, and that mixes the right blood with the left blood, and that creates the cyanosis. Understood? But how is the circulation to the lungs? Oligamic or plethoric? Oligamic, because there is a pulmonic stenosis now, obvious. There is a doubt. Tell loudly, confidently, though you are listening for first time. So how is the lung blood flow to the lungs? Oligamic. In TOF. TOF, you know what is the problem? The problem why it is a cyanotic heart disease, you should know by now. Right? The blood comes into right atrium, into right ventricle, and instead of going into pulmonic artery, it will go into overriding aorta, which is opening mouth into both right ventricle and also the left ventricle, and that mixes the right with the left blood, and that creates the cyanosis. Understand? Now, this is oligamic. If there is a tricuspid atresia, it is also cyanotic. Why? What is the problem in case of tricuspid atresia? Typically, the tricuspid is atretic. The blood cannot negotiate from right atrium to left atrium. Instead, it will negotiate through ASD. So that right blood goes into left side, and that leads to cyanosis. So this is also cyanotic. But how is the circulation to the lungs? Oligamic or plethoric? Huh? Loud. Oligamic. Very good. This is also oligamic. Just before we have seen TAPVC is total anomalous pulmonary venous circulation. Oligamic or plethoric? Plethoric. Excellent. There is a question of wondering about it. Then truncus arteriosus. Truncus arteriosus is like aorta and pulmonary artery. The septum is missing. Nice mixture occur. Cyanotic. But here there is an increased blood flow through. Systemic and pulmonary became one. So obviously more circulation will go to lungs. So this is also plethoric. So whenever you have a cyanotic child, look at his X-ray. If the lungs are plethoric, it could be TAPVC or truncus. If the lungs are oligamic, it is likely to be TOF or tricuspid atresia. That is what you need to basically remember. So we discussed all these things, doctor, and made available in anatomy2medicine.com, just like MS Dhoni story untold. You have to go back and do practice of batting. That's the only thing you need to do, right? So really good movie after a long time. Yeah. So a 3-year-old presents with a history of constipation, abdominal distension. Imaging has been shown. So what do you see here? A part of the bowel is contracted and the other part is being dilated, and constipation as a problem is classical of Hirschsprung's disease. And typically you are having that juncture between a ganglionic and ganglionic segment at the level of the descending colon. Sometimes it will be at rectum, sometimes it will be at the level of the sigmoid. So anywhere that point of transition zone can be there. A young healthy male with abdominal pain and history of altered bowel habits. CT has been shown, and vascularity of the adjoining mesentery is also increased, and there is a creeping mesenteric fat. So having had been given so many clues about this patient, what could it be? It could be TB because of the involvement of the thickening of the bowel. It could be Crohn's, but never ulcerative colitis. Ulcerative colitis cannot cause such a thickening, and creeping fat is not a feature of ulcerative colitis but Crohn's. In a patient presenting with a swelling of the thyroid, the radionuclide scan is being done. What is it showing? A cold nodule it is showing. It is showing a coal nodule. And there is a non-cystic solid mass which is being found when you have done the ultrasound. So what is the best line of treatment? Hemithyroidectomy is the best option which is available. Now what do you see here? This swelling is typical of a congenital brachial cyst. So if you look at the brachial cysts, they cause dysphagia more common than sinuses, and sinus should always be operated. They are all true, right? Once more, Ludwig's angina, salivary gland tumors, cystic hygroma, brachial cyst. Oh, surgery is like a bliss to read, doctor, right? You should be thorough. These are all high yield topics. Examiner, a lot of people ignore salivary tumors. Itna important hai kya? Alright, if you take the analysis of the last 15 years of All India, DNB, PGI and AIMS question bank and classify the questions from which topic they came. Every chart, top 10 topics mein salivary tumors rehta. But we ignore it. Alright, salivary tumors mein, oh, ek pleomorphic adenoma rehta, ek neurological involvement will be there in, actually the truth is that only, but you should also be quite sure that at least 15-20 points are there which you should be ready. The discharge from the nipple, what do you see here? A red colored discharge which is bloody discharge. Whenever bloody discharge is there, more likely to be a duct papilloma is what need to be remembered. A 55-year-old comes with obstructive jaundice and along with a weight loss, and the CT scan has been shown. What do you see in this? The pancreatic duct is dilated, same time there is a dilatation of the common bile duct. So two ducts getting dilated is called double duct sign, which is a classical feature of a periampullary carcinoma, is what you have to basically remember. So this is, for example, this is typically the CVD which is dilated. This is a mass lesion, common bile duct dilatation, and pancreatic duct also dilated. So this is called double duct sign, right? NEET PG prepare होके आप half radiology MD खत्म करते, हाँ? So this is a normal pancreas. See, pancreas will be sleeping like Sri Mahavishnu in Padmanabha temple in Trivandrum. So it will be lying down like a extended statue, right? Then this is the gallbladder, liver, then you have the stomach, and there is a splenic vein when you pass the contrast, and this is the typical spleen, kidney, and you have got a speck of vision of adrenal. So 3-4 times when you see the pictures, automatically these cross sections you will understand. Now there is a salivary tumor whose histology is being presented, and it has got a lot of collection of lymphoid tissue, which is a classical feature of Warthin's tumor. So you should know what is true and false statements about it. A 40-year-old male with recurrent headaches has got a mass lesion hanging and attached to the dura mater. Hence, it is likely to be meningioma. Now, after the cataract surgery, patient developed this complication. What is this complication that can occur post-cataract surgery after 6 days? Typically, it is a endophthalmitis. So, to prevent endophthalmitis, what will you basically provide? Preoperative preparation with povidone iodine is considered to be the management. So, the appearance in the eye, what is you see? A band-like structure. Okay. On the newsformedico.com, you have got a blog of all these images. And so, hope while taking tests, still students are coming for a paper-based exam to have like temple like a thing. So, we can't give color prints, very costly affair, no point also, right? So, review the digital images while taking test, that's important. So, it is a band-shaped keratopathy, and band-shaped keratopathy should be treated is because of the deposition of the calcium. A 35-year-old male presented with a 15-day history of proptosis in the right eye and the pain on eye movement and there's a difficulty in upward and downward gaze movements, and CT scan shows a cystic lesion, which is classical feature of cysticercosis cellulose in the orbit. Now, a male patient with history of hypermature cataract after 2 days, within a 2-day with a 2-day history of ciliary congestion, photophobia, blurring of vision, and the eye is being shown. So classically you are finding uveitis. So it is a phacoanaphylactic uveitis, and very commonly there is a confusion between endophthalmitis and the phacoanaphylactic uveitis, but the plot-like material in the capsular bag post cataract is an indication that it is a phacoanaphylactic. Some material of the lens is being left and it is causing the hypersensitivity reaction, irritation, leading to anaphylactic uveitis. So to demonstrate that small material of the lens is important to prove that it is a phacoanaphylactic uveitis but not the endophthalmitis, which is also a complication expected to happen post-operatively after a cataract surgery. Now what is the lesion which is being shown? It is a chalagion. So chalagion is fundamentally a lipogranulomatous inflammation, chronic inflammation, most commonly in second is very commonly because of some ophthalmologists say due to heat. So external hordeolum, internal hordeolum, all these things, 4-5 points you have to be sure. Recently we had an excellent class by Dr. Rajaratnam, who came all the way from Chennai to deliver an ophthalmology review of last 15 years all India. So she is going to come once more to review the last 15 years of AIIMS question bank, topic wise analyzed. So her videos will once more be available in anatomy2medicine.com. Please review. An orbital tumor in figure has the following features. So it is basically a retroorbital mass lesion in the is what you are classically finding, right? Could you appreciate that? So it is easily resectable, capsulated lesion, and typically it is occurring between 2nd to 4th decade very commonly. So what is this retroorbital lesion which has all these characteristics of being capsulated, etc., etc. And also what is it leading to? Proptosis. So it is a classical feature of cavernous hemangiomas, typically present with proptosis. They are very well encapsulated lesions is what you need to remember. So this week we have last 15 years of all India around 400 orthopedics questions, another 350 AIIMS last 15 years question papers topic wise are going to be reviewed and revised by one of the very good orthopedic surgeon. So please do come and enjoy the class. Now a 12-year-old boy comes to the room with this is a beautiful question on strabismus, right? So every exam entrance may one question on strabismus come. Only those who prepared will answer. And if you answered that correctly, take it granted that around 10,000 people you have pushed and moved forward. It's like Sixer Barna, right? So what is primary deviation, secondary deviation, concomitant squint, etc., etc. And how do you manage amblyopias? When will you do occlusion therapy? What are the criteria to stop occlusion therapy, right? And individually, superior oblique or inferior oblique, right side or left side, based on the head tilt, all this funda, hardly 1 hour you will take. So we have once more the review lecture of all the theory of strabismus available in the Anatomy to Medicine video library. So here the person has tilted towards the which side? Right side or left side? This side, no? Left side he tilted. Then whenever you are tilting his head, then the eye is deviating up, right? And typically the tilt is worsening by certain features, which are all classical feature of right superior oblique paralysis. So what is the line of action of the muscle and what line diplopia will be generated, all those things you need to take a little, if I start speaking the story, it will take another 45 minutes is over on that only. We did that all with all more pictorial discussion available in the video library. Please review that. A renal stone is formed by which anti-epileptic drug? Topiramate is the one which is known to lead to it. Then for the recombinant tissue plasminogen for you to administer, there are certain important absolute and relative contraindications which you have to be very sure about, and a low platelet count is one such contraindication you need to be wary about while you are administering the thrombolytic agents is what I want to underscore. Lateral medullary syndrome, the descending sympathetic tract passes lateral part of medulla. Medulla may you have 8th, 9th, 10th cranial nerves. Medulla is connected with inferior cerebellar peduncle with the cerebellum, right? And medulla is the point where the pyramidal tract descends down and goes into decussation while passing through the medulla. So if you know which structures are involved in the lateral medulla, what is their function, which get decussated, which are undecussated, then you can be able to answer all these questions. A third nerve palsy with a contralateral ataxia is typically called the Claude syndrome. So what do you see here? There is a ptosis, right? But contralateral to the side of that there is a ataxia. Then you call it as Claude syndrome. So there is a contralateral hemiparesis, contralateral ataxia, and oculomotor nerve palsy, which is the combination which is called as the Claude syndrome, which is because the midbrain infarction due to the occlusion of a branch of posterior cerebral artery. So why there will be contralateral ataxia? Because through the midbrain is connected to the cerebellum by superior cerebellar peduncle. Don't keep such innocent face, I feel. So these are all the things, doctor. October, November में पढ़ने वाला चीज नहीं है ये. Neuroanatomy and all that, if you would have read, you must have read long back, right? So don't spoil your mood and go into tension. Only required things only you read and go to the exam. Very focused thing. Brainstem Syndromes is one video lecture available in anatomytomedicine.com. Just review that. Half an hour you will become pundits. What is Claude syndrome, Benedict syndrome, North-Nagel syndrome, all these brainstem syndromes. But for your understanding, we have a midbrain where 3rd and 4th cranial nerve nuclei are there. Pons where 5th, 6th and 7th are there. And medulla where 8th, 9th and all the remaining are there. So this midbrain is connected to the cerebellar dentate nuclei, and the cerebellum as such is connected with inferior cerebellar peduncle with medulla, middle cerebellar peduncle with the pons, superior cerebellar peduncle with the midbrain. So this midbrain and the cerebellum are connected by the dentatorubral fibers. So they get affected whenever there is infarction in the midbrain, and that lead to development of ataxia. Then your corticospinal tract, which is also called pyramidal tract. It starts in the motor cortex, passes through the internal capsule, passes through the brainstem, and while passing through the midbrain, pons and medulla, it passes ipsilaterally. In the lower part of the medulla, it crosses to the contralateral side, and while passing through the midbrain, whenever it get affected, contralateral side you will get hemiplegia. And because your midbrain is housing the 3rd cranial nerve nucleus, any midbrain infarction should lead to 3rd nerve palsy, contralateral hemiplegia, and also there is a ataxia. So this combination then is called as Claude, is what I want to underscore to all of you. Now these are all the reversible causes of the dementia, but not Biswanger. Biswanger is the small vessel disease due to arterial lipohyalinosis. Whenever there is atherosclerosis, then small vessels which are the ones going to the deep matter, the white matter, they are the ones which get affected and that lead to dementia. So Binswanger's disease is irreversible. Now there is a meningitis with lymphocytic pleocytosis but a low glucose concentration. So it can be fungal listeria or TB but not pyogenic. Pyogenic will lead to neutrophilic leukocytosis. Caricombs murmur is a mid-diastolic murmur which is caused by mitral valvulitis when the mitral valves are inflamed in acute rheumatic fever, not in chronic rheumatic fever. In chronic rheumatic fever, mitral valve shrinks and forms mitral stenosis and that lead to mid-diastolic rumble, right? That is different. Hyperkalemia can lead to development of a prominent T wave, decreased P wave amplitude and widening of the QRS. U wave is a feature of hypokalemia, not hyper. Then which is a class 3 antiarrhythmic drug, Pratillium, Albuterol, Dofetilide, they are all fundamentally class 3. If you have done this question wrong, doctor, quickly go back and review antiarrhythmic drugs. Definitely one question will be asked. 1A is quinidine procainamide disopyramide, 1B is lidocaine mexiletine phenytoin, and 1C is flecainide, encainide and propafenone is what need to be remembered. With this question I will conclude the today's class. Constrictive pericarditis, what is absent feature? Pulsus paradoxus is a feature of cardiac tamponade, right? Not constrictive pericarditis. That's what you need to remember. So thanks for a patient listening, doctor.